we talking here about a basic ventilator strategy, you will probably see each baby with the same disease behaving differently, and you may have to tailor it according to the pathophysiology. So I think we had one or two classes before this where we talked about the respiratory physiology. So you have to think what pathophysiology, not only the disease, but what pathophysiology is being encountered by this baby. Now before that, let's go on to the knobs on the ventilator, which determine how the ventilation happens. So if you look, I've typically most people would have seen a Draeger ventilator, which is like one of the oldest one which is available for long, and it constituted only 6 knobs on the top of it. Although I can't show you like with a pointer here. If I have Okay, so then there are 6 knobs. The first, which was a slightly blue knob, is an oxygen concentration somewhere between 21 to 100%. So that is like the FI2, or the fractional oxygen fractional oxygen concentration. So how much we need to give an oxygen to the child is determined by this knob. The second knob that you see like is a TI, and the third one you see here is a TE. So TI is inspiratory time. So you set at inspiratory time that you want the ventilator to work for that long, and I will explain how it works. The third one is expiratory time, which determines the amount of expiration. But because Ti plus Te is equal to the rate, so if you have to change the rate, so either you have to change the Ti or you have to change the Te. Now Ti would remain more or less the same, or more or less constant. So for changing the rate, you would end up moving the Te. Some ventilators would have a direct option of changing the rate from 40, 50, 60. In that case, those ventilators do not have a separate TE, they have a TI state. Then there is the one in the bottom line is the inspiratory flow, because you need the flow of gas to go and cause the distension of just 1 minute. Apologies for the same. Now, are you able to hear me?
Yes, 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 yes.
Yes, sir. Yes, sir.
Some phone call on the computer itself. So then there is the fifth knob that we're talking about is a inspirating peak pressure, or a PIP. So this is the amount of pressure required to inflate the lung, and the last one is the PEEP, or the expiratory pressure, which keeps the lung open. Now the ventilator also, the one you see, one is an inspiratory limb which is going towards the tubing, and one in the expiratory limb. So all these things functions, the air goes, and on the back of this ventilator the air comes in, it goes through as a circuit, and these are the knobs which control. So we will talk about these things, and before that let me explain how the ventilator actually works. Is that there is this red dotted line that you see is a continuous flow of air which is going into the circuit. So this is called a bias flow, or which means that is a baseline flow which is going on. Now what happens is that you would use like a kind of a resistance. This is a sickening. So this is a baseline flow like which is going on, and when you apply a small amount of a pressure here, so there is a pressure which the air, because it's like an obstruction that you create at the expiratory limb. So there is the part of this flow, this actually goes into the baby, and that causes the air to flow. When you apply a TI or a full inspiratory pressure, so then you see more air going into the baby. So what happens is, like if I explain it to you again, so here is a child who has a PEEP. Now we apply this green button or a more obstruction. So this creates more pressure to be delivered into the baby. So this created is known as a PIP, and the amount of time that you keep this PIP there is called a TI. So then once you release, the more air can flow out of the expiratory valve and less of the air goes into the baby. So the pressure being delivered to the baby also decreases. So this is how the ventilator works on this. So in practice, if you see, so the oxygenation we see are there are factors which is PEEP. So when you determine the map is the mean airway pressure, which is determines how much of the oxygenation of the lung can happen. So it is determined by the PIP, is determined by the PEEP, it is determined by the flow rate to some extent by the rates, and also the inspiratory time. Now, if you have to improve the oxygenation in babies, then we need to see how do we do it. So the possible areas are that we increase the PEEP, and if you see, like you would see the maximum amount of area change which happens is because of a PEEP, because PEEP is applied throughout the inspiration and the expiration. So the maximum amount of change in map can happen because of the PEEP. So the first strategy that we look at whenever we have to ventilate a lung is to ensure that we have at least an optimum PEEP, because that's the way we can improve the oxygenation. The other strategies that we can look at is, like, you can increase the PIP or the peak inspiratory pressure, but as you can see, the amount of change that can happen with increasing the PIP is only small. And you can imagine PIP is like a middle order batsman Virat Kohli who stabilizes. PIP is like, sometimes might work, sometimes may not work. So overinflation can actually be bad. So PIP is one of the strategies, but first we should look at PIP as optimizing the PIP. Then you can increase the inspiratory time, but as you see, as the inspiratory time increases, you may end up compromising the expiratory time, which means that you may actually cause overinflation, or you may cause like retention of the CO2, because the lung does not have a time to expire out. So you can increase the TI, but you have to be worried about generating, like, obstructing the lung or obstructing the expiration as such. On the other hand, what determines the CO2 removal is the amount of inflation that you see whenever you inflate a lung. So the more the inflation, the more the chances that more the alveolar ventilation, and more the chances that you will remove the CO2. So in that case also, the first thing, the three parameters which would determine the CO2 removal is the PIP. So once you increase the PIP, your CO2 retention would increase, your removal would increase. When you look at increasing the rates, so that your CO2 removal will increase further. Say for example, if I have a CO2 retention, I'll breathe faster so I can remove more air, and if I breathe deeper and faster, so I can remove more oxygen, yeah, more carbon dioxide. But one of the things that one also must remember, that apart from the change in the PIP and the rates, you also have to optimize the PEEP. So which we normally associated with only with the oxygenation, but if you have a suboptimum PEEP, your lung is going to be at a lactated and in atelectasis your probably CO2 retention is not optimum, so you want to expand the lung to get into a normal a part of the PV loop where your expansion helps you remove the oxygen, remove the carbon dioxide well. So whenever you talk about a mechanical ventilator breath, there are three things that one must understand. One is that what triggers the breath. So when the ventilator has to sense or has to be told when to start, this is the time, please start the breath. But ventilator also needs to be told, okay, this is your limit beyond which you should not give it, because if you leave it limitless, it can cause more damage. And then you also need to tell the ventilator, please stop the breath now and let the baby breathe on its own or whatever it needs to be done. But that is the way. So starting, limiting, and cycling. So these are the three things whenever you keep in mind. These are the factors which are responsible for a mechanical breath. So trigger generally is like what initiates the breath. So the breath can be initiated by two methods. So the ventilator senses the that the baby is breathing by two methods. One is that flow. So there is, for example, a 5-liter flow going into the circuit. Now the baby breathes in like zero point 0.2 liters of air in that. I'm a very hypothetical explanation, but the trigger is set at zero point 0.5. Okay, the ventilator does not know whether the baby has actually taken a breath or not taken a breath. Okay, on the contrary, if the baby breathes a little and it takes in 0.5 ml and the ventilator is set, trigger is set at 0.5, for example, so the ventilator now knows that the baby has taken a breath and it is time for me to start the breath. So with this, like the baby's breath can be coincided with the ventilator breath. So if the baby's breathing is like so this is about the flow trigger. On the contrary, and the pressure trigger works along the same line but in a different mechanism, that it picks up the drop in pressure. So whenever the baby breathes in, there is a slight drop in pressure in the circuit. So that circuit pressure, once is detected by the flow sensor or like the flow sensor, then it says, okay, it is time for me to start a breath. So the difference between the flow triggering and the pressure triggering is that flow trigger is generally, it helps in better synchronization, and you have lesser or a reduced work of breathing in the neonate with the flow trigger, and it has more sensitivity, so it can detect smaller inspiratory efforts because it detects the flow, contrary to the pressure difference, which is less sensitive. Okay, but there are problems with the flow triggering also, that it tends to be also, it increases because it is oversensitive. It tends to also increase the risk of autocycling, which means that, like, small movement, secretions, or even small circuit noise, they can actually initiate the breath, because ventilator does not have a brain. It only picks up that flow change. So if there are secretions or there are movements in the circuit, and that causes, so that can cause autocycling. And of course, it may not function effectively in presence of significant air leaks. And in those scenarios, pressure triggering slightly is better. So for very small children, we need to look at flow triggers. That should have our first priority. But if we have a very larger leak, sometimes flow may not work, so you may use a pressure if you have a choice to choose between the two. But most ventilators nowadays have only one kind of a triggering available. Now, the second thing, as I said, we need to decide what is the limit. Limit means that there is a pressure limited ventilation or there is a volume limited ventilation. As the name suggests, the pressure is limited. So we know, okay, beyond this, the ventilator is told, I order you not to go beyond 20 mm, 20, pip. So with 20 pip, there is a volume which is variable, because sometimes what happens is that the compliance is like good. With that 20, you may have an overinflation. If the compliance is poor, with that 20, you may have an underinflation. So in a pressure limited, your intent is to reduce the barotrauma, but your volume keeps changing and you end up having a volume trauma. On the contrary, like when we look at a volume limited ventilation, the volume remains same. So we tell the ventilator that please deliver 10 ml, or 5 ml per kg or 10 ml of total volume to the inspiratory circuit, and then you would give that volume into the circuit, and with that the pressure would vary. So with this is like how you would look at the volume limited, but there is something called a volume targeted, and volume targeted ventilation means that it works on something like an algorithm which is defined by the each ventilator. So what it does is that you set a target volume. So if, for example, volume, you see a dragger ventilator which has a PSV with a volume guarantee, or most of these like SLEs who have targeted tidal volume. So you set a target tidal volume. Suppose you set 5 ml total target volume. Now, the ventilator says that the first breath was like in this first case, for example, the ventilator senses through the flow sensor that the tidal volume was 6 ml. Now, based on this expired tidal volume, it tells the ventilator probably you don't need to give that much of a pressure. Please reduce the pressure. So it says, okay, previously you had used 18 pressure. This time I'll give you like 2 or 3 less. Say, for example, it will give you 15. Now at 14 or 15, the volume delivered, for example, in this case, may be lesser. So it says, okay, with 14, the ventilator delivered, you set at 5, but it gave only 4. Now the ventilator says, okay, expired volume was 4. Now I need to boost it up. So instead of going from 18, now it says, okay, let me go to 16. So it's 16 is a square, I achieve 15, and that means that for every expired volume, it keeps changing the pressure to accommodate a targeted volume with the intent of preventing a volume trauma as as well as a barotrauma. So that is why this mode of volume targeted ventilation with other pressure limited ventilation has become a norm for most of the units who are using ventilation, especially the smaller babies. They do excellent as far as, unless there is a large amount of a leak. So the difference between a volume limited and a volume guarantee. So this is like, again, you need to understand because I just explained how it works differently. So volume guarantee works done on an expiration. The pressure varies, depends on the pressure measured in the previous breath. Okay. And it can also compensate to some extent for the leak, maintaining the target volume. Volume limit, on the other hand, is based on the volume being supplied into the inspiratory volume, and there is no leak compensation. So it may result in a hypoventilation if the set volume is too low. So the last thing that the ventilator is that now the ventilator must know I need to stop, and the stopping of the ventilation can be done by two methods. One is time. I tell the ventilator, please after 0.5 second stop and go back into the PEEP mode, or maintain the PEEP, release the expiratory valve, and do not keep the PEEP going at that time. So that is based on a time. On the other hand, when I breathe, my flow goes up, and in the inspiratory cycle also goes down, because the peak happens of the flow happens somewhere in the middle of the inspiration, not towards, although we tend to think in like, so the maximum happens towards the end, but the maximum is in the, so it's a U-shaped curve. So when you're reaching the inflation of the lung or the maximum capacity of the lung, your inflow or a flow rate actually goes down. So you may see, okay, cycling can happen when the flow drops to a particular level set by the doctor. So if I say I need to stop flow at 15% of a peak flow, so suppose the flow for any length of time was 1 liter, and again an hypothetical not related to baby, for explanation purposes, 1 liter, and the flow drops to 0.15 liter, then the ventilator must stop even if it is giving the breath. So with what happens with this is that not only the trigger which started with the flow triggering, but since the flow cycling is also happening, both my inspiration is kind of getting synchronized, and my expiration is also getting synchronized. Because normally in time cycling, sometimes the baby may have like may still be taking breath, and the ventilator may say my time is up, I am stopping, and I want to stop and let the baby breathe. But on the other hand, sometimes when the baby has stopped breathing, baby wants to go into an expiration, but the ventilator says, no, my time is not up. So I need to give you for that another, length of time which was stipulated by the doctor. So even if you're breathing out and you're going into an expiration mode, I still want to give you the breath because that has been decided. So that is why flow cycling is something that we also prefer nowadays. And flow cycle, one of the commonest is pressure support ventilation, and we'll just talk about. So this is a child who's probably, you see the breathing, and when the peak flow happens at 15% of the flow, and you can, some ventilators give you a chance to move somewhere between 5 to almost 25% of the peak flow, and that can determine. So looking at the flow graphs, which will be again covered in one of the further lectures, that you can just set what is the right optimum peak flow where the cycling has to be done. So ventilator modes, like earlier, used to come as a very simplistic. When we started our residency, there was like only CMV or SIMV, and then we started learning. By the time we started leaving, people started gathering interest into other modes, and I remember towards the end of my DM, we started using an SIPP or assist control, and that too very sparingly. But now we have like hybrid modes, which Ashish is going to talk about, where you have a combination of various, and which Dr. Rajesh was saying, SIMV with pressure support, that kind of a mode. But for the beginner, I need to explain what is an CMV breath, SIMV, and SS control, and pressure support. Now, if you see, the green one is the spontaneous breath, and the yellow one is the breath from the ventilator. If you are breathing like this in CMV, is controlled mandatory ventilation, that I control the breathing of the child completely, and I ask the ventilator, I do not really bother about what the baby is doing, but you need to deliver the baby this much pressure, this much PEEP, this much inspiratory time, and at a fixed rate. So do not bother about what the baby is doing. But the problem with this thing is that sometimes the baby, like in the first case, the baby is starting to breathe. It may have started early, and by the time it's reached the middle of his respiration, the baby is like the ventilator starts breathing. Although it's a very theoretical kind of a thing, but because most of the times people used to use CMV in paralyzed babies or apneic babies or the ones who were not breathing. But then the baby may breathe in between on its own rate, and then after a time, because the ventilator is set to at a particular rate, it starts giving a breath again. Now this might what might happen is that when the ventilator now starts going into expiration, the baby starts breathing. So there is a complete asynchrony between the ventilator and the baby. So this is the most uncommon form of ventilation, and nobody uses like as in a awake child or in a spontaneously breathing child, the CMV. SIMV, on the other hand, as I said, is the IMV or a CMV with the synchronization. Now, what happens is, whether it is a flow triggered or a pressure triggered, the ventilator, the moment the baby starts breathing, the ventilator delivers a breath, so that there is an inspiratory synchrony. So the moment little baby breath, the ventilator boosts up. Okay, but what happens in SIMV is that you set a rate. Say you set a rate of, for example, 30. So the ventilator in 1 minute will give you a 30 breaths, but suppose the baby is breathing at 60, so rest 30 breaths the baby is going to breathe has no support coming from the ventilator. So it is like, so baby is like partially supported. So you may increase the rate to 40, for example, the 40 breaths get supported, 20 unsupported. Decrease the rate to 20, like 20 supported, 60 not supported. On the other hand, like assist control or SIPPV is a ventilator strategy where every breath is supported. So baby breathe, the baby breathes, the ventilator breathes. Baby breathes again, the ventilator breathes again. So with this, what happens is that like this results in every breath. So the baby, suppose you set at a ventilator rate of the baby is breathing at, say, hypothetically 60, then every single breath of the child would be supported. Now the baby is breathing at, suppose, 40, so every single 40 breaths would be supported by the ventilator, if the trigger criteria is met. On the other hand, like pressure support ventilation. So pressure support ventilator is that like you have a ventilator, a pressure boost, which means that I am breathing and the ventilator breathes to help me, provide me an extra pressure boost. Now, it is almost similar to SS control. The only thing is that you can actually change the pressure setting. So you say, okay, for the SIMV breaths, for example, which Dr. Rajesh was mentioning, I set a particular PEEP. In this case, for example, I've set it 16, but I set a pressure support of 50% of this thing. So then I need 8 of boost for the spontaneous breaths which the baby is breathing. So in this case also, now every breath would be supported, but some of the breaths would be supported partially, some would be supported completely. So it is like a good weaning mode. So from, when you use an SIMV with a pressure support. The other thing about and how you differentiate PSV from an assist control, because every breath is supported. In this case, because there is a flow cycling, the TI would vary for each of the spontaneous breaths which are not the SIMV breaths. So in this case, there is a better synchrony than the babies who are only on assist control, because here you have both the inspiratory and the expiratory synchrony happening. So after this brief, whatever you use, you need to put the baby onto a ventilator. You must remember to check 3 things. You should observe the baby. So look at a color and a circulation. So if your child is becoming pale, or it is looking blue, or the oxygenation is not achieving, then you have something not going right with the baby or the ventilator. Then the second thing that you want to pick up is look at a baby's respiration, and also see whether the baby is fighting the ventilator or not. If the baby is fighting, of course there is something not right, because the baby is not comfortable with the support that you're providing. Then look at a chest rise. So you should go towards the side, and because to avoid a parallax error, from the side you see whether the chest rise is happening. If the chest rise is happening and you can see up and down movements, that you are actually causing an inflation of the lung. And with experience, you will be able to even tell whether this is a right kind of a chest expansion, because with experience you can tell whether this is hyperinflation or hyperinflation, and you may be able to check or reduce the tidal volume or the pressure. Then you need to look at whether your gastric distension is happening, or work of breathing is increasing or not, or decreasing, because the purpose of ventilation is to reduce the work of breathing. On auscultation, you should always check a breath sounds to all lung areas. You should look at adventitial sounds, and you should look at heart sounds to see if there is like any kind of a muffling or there is an hyper expansion. And then always there is a screen on the each ventilator which gives you a lot of information, but often overlooked because we are engrossed with only few numbers, PIP 20 by 5, 16 by, but whether that 20 by 5 is right or not, you need to look at delivered volume, and you should always look at a flow time curves, because they would give you an idea whether the aim with which you started in ventilation, whether we are achieving that right or not. Now, an ideal ventilator screen because should look like this. You have a respiratory distress syndrome. You press that button and you have a pneumonia or a BPD. You press that button and you should be able to ventilate. And that is like we hope in future with AI coming in, we might have such a ventilator. But right now, all machines come with a caution that the machine does not have a brain, so we must use our own brains to determine what is the right strategy and what kind of a mode, what kind of settings we can set to help the child come out of the pathology from which it is suffering. So when we look at a ventilator, we need to look at what is the type of ventilator, whether using a high frequency ventilation or a the conventional ventilation, and what mode of conventional ventilation that you need to use, whether how do you decrease the work of breathing and reduce the ventilator induced lung injury with a targeted volume strategy. We must always understand the pathophysiology of a disease, and more importantly is evolution over time. HMD on day 1 and HMD on day 4 are completely different diseases, and we must plan extubation even at the time of intubation, because we all understand the risk of like putting a child on a ventilator. And so how we should not be like Abhimanyu, where we do not know how to get out after putting in. So when we look at a respiratory distress syndrome, it is quite a common problem among, and almost say, like between 28 to 32 weeks, almost 60 to 70% of the children would have respiratory distress syndrome. And even bigger babies, like when we say 34, 35, 36 weeks, almost 10 to 15% of those also would have a respiratory distress syndrome. And even at 38 weeks, 1% of the babies would have. So we tend to put them into CPAP, and that should be our first strategy. But we know that those who are less than 750 grams, less than 26 weeks, are more likely to fail CPAP. Although it doesn't mean that we should not try, but the prediction is that you would probably end up intubating these babies sooner or later. The incidence of BPD keeps increasing and almost reaches like to the tune of 70% at 23 weeks. So now that we are saving more and more of smaller babies, we should be aware of this entity, and we should also know how to manage, because BPD, milder ones could still be forgiving, but severe BPD is one of the nightmares for a neonatologist to manage. So the first disease we commonly talk about is the child who has an RDS pathophysiology or a hyaline membrane disease. Now, as all of us know that this is a disease which is characterized by lack of surfactant. Lack of surfactant causes atelectasis, and atelectasis causes the impaired oxygenation and CO2. So when we understand that, the first thing that we need to do is to prevent this atelectasis or counter that atelectasis to open up the lung. So the idea is to have a recruitment of the lung without damaging the lung. So you don't want to like cause overinflation, and there are various methods: flow trauma, rheotrauma, barotrauma, volutrauma, biotrauma, other ways you can damage the lungs. But idea is recruit the lung, get into the middle part of the PV loop of the lung without causing damage to the lung. So setting an RDS is generally you would want to, like as I said in the first slide, the map oxygenation is to optimize the PEEP. So you want to get a PEEP in the range of around 6 to 8 centimeter water, when we started our career, we were told like 12 by 4 or 16 by 4, and if we had to reach a peep of 5, we would have jitters. And I remember in my DM, probably rarely we use 6 or peep. Now we rarely use a peep of 5, and we generally start with 6 and then go up, because we over a period of time realize that peep is something which helps the lung open up. Pip enough to cause a target tidal volume of 4 to 5 ml per kg, and this should be corroborated with a flow curve that you see, and also on the bedside with an adequate chest expansion. Now, since RDS is a disease which is mainly a compliance problem, like there is no resistance problem, so the compliance issue, which means the time constant in this case, because the compliance is low, the time constant is low, so you would want to use a shorter inspiratory time. If you use a very long, inspiratory time, this will overinflate or keep the lung stretched for a longer time, causing more trauma. So you want a shorter inspiratory time, but not very short, because you need some time for the lung to expand. So typically what we say that sorry when we say we want to keep the inspiratory time somewhere around zero point 0.3 to 0.35, because and then you can make a change based on looking at a flow time curve, so whether that inspiration is complete or not, and rates somewhere between 40 to 60 that we tend to keep. Less than 40, probably the risk of barotrauma or pneumothorax is higher. So we generally try to use slightly higher rates if you have to use the. But if you're using a ventilator strategy like an assist control, then we need to look at the baby sounds. Yes, excuse me. Sorry, this is, I don't know how to set this off. Uh, so, okay. So the next thing that we need to look at is the volume targeted mode. Now, whenever you use the baby on a RDS, the idea is that we need to prevent the volume trauma, but also not cause hyper ventilation. So as hypocarbia needs to be also protected, because hypocarbia is associated with PVL or periventricular leukomalacia, and then you would need to look at preventing a volume trauma. The last thing that we need to prevent is an atelectative trauma, which means that if you keep a lung volume PEEP which is low, so every time the lung, it opens and it collapses, and it opens and it collapses. But if it collapses and it has to open up again, this causes a lot of shear trauma to the alveoli, and they tend to get into a ventilator induced lung injury. So at the current moment, I would suggest that it is unfair not to use a volume targeted mode of ventilation in RDS unless there is a huge leak. There are some centers in the Europe, and most of them in fact, who use pressure support with the volume guarantee as the primary mode for all babies who are smaller babies on ventilator. So with pressure support, what they do is synchronize every breath. They make sure that it is flow cycled, so inspiration and expiration is synchronized, and volume targeted make sure that the child doesn't get into at least that much of a volume is delivered, so that optimizes the ventilation. So in which mode of mechanical ventilation? In acute phase, it is always better to use an assist control rather than an SIMV, so that every breath is volume targeted, And assist control also helps in making sure that every breath is supported rather than an SIMV. So plain SIMV is probably not right. SIMV with pressure support or an assist control or a pressure support with an volume guarantee is the best way to ventilate all the babies who are on RDS. Now, as far as meconium aspiration is concerned, meconium is not a single disease. So we generally say like the pathophysiology of a meconium can vary from a complete surfactant deficiency, which means that you're like because the meconium has damaged the surfactant, the lung is collapsed, is atelectasis, something behaving like an HMD. On the other hand, because the meconium itself can act as a partial valvular mechanism obstruction. So because meconium goes there, the air goes in, but because of this valve cannot come out, so there is air trapping, so it is behaving more like an asthma kind of a condition. Or sometimes there is like a pulmonary hypertension. There is not much problem with the lung, but predominantly it's the shunting which is causing the child to behave and cause hypoxia. In all those cases, your strategy would be completely different, and we'll talk about PPHN in a minute. So what is important again is to the idea behind this slide is that meconium is not a uniform disease as regards the ventilation, and every child needs to behave slightly differently. Now, meconium aspiration, if it is behaving like an RDS, so you say, okay, this is a whiteout lung in case of an meconium aspiration. So you have the same, more or less the same strategy, the PEEP which is high around 6 to 8. You have like TI which is 0.35 to 0.45, PEEP according to the inflation. And these are the babies where giving surfactant may actually help the babies. On the other hand, this is also meconium where it's more like an obstructive pathology. And in this case, if you see, there is an increased resistance. So the air is going in, but in the air coming out is difficult. So in these cases, the time constant, especially the expiratory time constant, is like high. And these are also the cases where the increased lung volume is there because of the obstruction and gas trapping. So in these cases, volume targeted SIMV may be better than assist control, because auto PEEP or dynamic PEEP can cause further air trapping, because if every breath is kind of supported. So in these cases, we tend to use a volume targeted SIMV rather than assist control. We use a lower PEEP, generally 5 or so, and lower rates, because as I said, the expiratory time constant is high, so you need a longer time for the air to come out. And then you use a slightly higher tidal volume, because the higher there is a higher alveolar dead space volume, because most of the air which is going into the alveoli, some of it is not being used for gas exchange, and that is an alveolar dead space. So to compensate for that, you need a slightly higher volume. Now, when you talk about the bronchopulmonary dysplasia, in these cases, like the compliance could vary. Sometimes, like very mild BPD, the compliance could be quite good, or it is a fibrotic state already. Then, in that case, the compliance is very small, decreased. Resistance, however, is increased because of there is a significant fibrosis in the alveoli, into the trachea, and sometimes the distension of the trachea because of tracheomalacia or bronchomalacia also results in increased resistance. And the time constant, both inspiratory and expiratory, because also is increased because of increased compliance. So if you see, this is a child where you see where there is a central airway in BPD which is causing tracheomalacia. There is a subglottic stenosis, there is a granuloma, there is a bronchomalacia, and in smaller airways there is a structural modeling which causes mucous gland hyperplasia and smooth muscle hyperplasia, bronchoconstriction, hyperreactivity. All these things would result in a disturbed pathophysiology of BPD. If you see the picture down on the left hand side, the C1. So this is a child where see there are areas of lungs which are normal compliance and the normal resistance towards There are areas of lung which are low compliance and high resistance, and there are high compliance and resistance in this. And these areas you probably would need to use a shorter inspiratory time or a lower tidal volume. But if it is a very extensive kind of a BPD, for example, one on the right side, you see, in these areas, there are areas where there is a lot of bronchomalacia and trichomalacia. In this case, a lot of air would get lost somewhere into the bigger. So you have, like, say, for example, this tube. Tube can accommodate, say, 1 liter of air. Now, if this bronchomalacia, tracheum or bronchomalacia, this becomes distended. Because of this distension, the air accumulated in this would go back to something like 2 liters. So you have provided another 1 liter, but that still doesn't go further to the alveoli, because now this distended tube, which is the trachea or the bronchos, would actually result in distension and trapping that air, which cannot be used for gas exchange. So with that in mind, we need to understand that pathophysiological change is important to understand. And if you have a child who has a mild to moderate BPD, maybe a tidal volume of 5 to 8 is good enough, with the inspiratory time of 0.4 to 5, and you would use a slightly longer expiratory time, a lower rates, and keep a PEEP around 4 to 6. But the nightmare is generally a severe BPD. In those cases, because of tracheomalacia, because of increased alveolar dead space, because of like bronchomalacia, sometimes you need a very high tidal volume, something to the tune of 8 to 10, 12 ml per kg, because the effective volume which goes into the periphery of the lung is very less. So because this is a state where the inspiratory time constant is increased, so you may need a tidal inspiratory time of 0.5, 0.6, and we have also used sometimes 0.7, but in that case you need to allow enough time for the expiration. So use a very small rate, something like maybe 20, 25, something, to get allow the inspiration to happen and the expiration also to happen, because it's a very slow process through the damaged lung. And sometimes you have to use a very high PEEP, because the tracheomalacia or bronchomalacia tends to collapse easily and obstruct the airflow. So you want to use a higher PEEP to keep it expanded. At the same time, you have to see what is the impact it has on the peripheral part of the lung. The congenital diaphragmatic hernia is another part which often gets like coming into the NICU, and we need to look at what can be done to improve the ventilation in this strategy. The key pathophysiological features in congenital diaphragmatic hernia is that because of the abdominal organ going into the lung, an impaired lung structure does happen, and most babies who are born with the CDH, especially if the CDH happened very early in the course of the disease in pregnancy, have an impaired lung growth or lung hypoplasia. Not only is the hypoplasia there, there is also a lung vascular maldevelopment which increases the pressure. And most cases we think only in terms of CDH being a problem with the lung, but there is equally a development of the left side of the heart, which leads to a left ventricular dysfunction. So all these things keeping in mind, one has to understand that the lung is small, so a low functional residual capacity is required. The pressure required to inflate the lungs would be smaller than the normal run. Okay, so this concept helps you decide how do you want to strategize. So when the baby is born at birth, so one, we understand that we do not want to give a CPAP or positive pressure ventilation, because of it causes gastric distension, further compromise of the lungs. But you also would want to target a oxygen saturation somewhere between 85 to 95 in the preductal, and in the first 2 hours it could be even lesser at 80 to 85. So don't keep jacking up the pressures, because in CDH you have not achieved. So if you achieve somewhere around 80-82% in the first 1 or 2 hours of life, please stay there, because if you go very high, you are likely to cause a pneumothorax, which is going to cause a problem. And of course, you can consider INO and a tidal volume, not more than 5 ml per kg. Again, because as I said, the lungs are hypoplastic and they can burst at any point of time. So you can start at a pip of 16, but 24, 25, that should be the maximum. The more likely you are going to increase, probably you're going to burst that lung. And PEEP, again, because of the smaller FRC, you want to keep somewhere around 4 to 5, targeting volume between 4 to 5 ml per kg. And if the PEEP needs more than 25, it's better to shift to a high frequency ventilation. The rate should be slightly high. Again, there is no scientific basis for this, but more or less we say, okay, this is a practice and convention and everybody is following. TI 0.3 to 0.35 smaller, again with the intention that we do not overextend or overexpand the lung. And the best way to look at is the contralateral lung inflation. And if you achieve 9 rips there, that probably you're overinflating there, and you just need to be around or slightly lesser than that. In a high frequency ventilation in CDH, you need to give a higher at 12, start at 12, but restrict it to maximum 16. We know people are talking about an open lung strategy where they go up to 20, 22 in a normal, otherwise like an RDS, but that is a strategy for RDS, not for a hypoplastic lung. Okay, you use a lower frequency, IE ratio of 1:2, and again making a looking at the other lung to determine what is the kind of an inflation that you need to look at. T fistula is another one that you probably would need to see once in a while. Again, there is no ventilator strategy which needs to be, because the lung is predominantly fine, but pre-op one must avoid a bag and mask ventilation and massive gastric distension, and there is a risk of an aspiration of a gastric contents. But post-op, most of these babies, because they have been unless you've done taken out the upper end in the cervical region, and if you've done a primary anastomosis, you should electively ventilate these babies for approximately 3 to 5 days, preferably. I generally prefer 5 days, because but sometimes some people are really brave to do it at 3 days, but I suggest 5 days would be. But do not extubate till the child is extremely stable on a low ventilator setting. And because once you start extubate and you have to re-intubate, if you have to re-intubate, that is a crisis. One, it has to be done with the most experienced person in the unit, and second, because you'll be extending lung, you have a risk of anastomosis giving away, which is most dreadful complication in TEF repair. So always make sure that you're not in a hurry as far as removing the baby from a ventilator if you have done a TEF. Other uncommon condition is gastrochaesis or large omphalocele. So in this case, the gastric contents are out of the body, and you, while surgery, either you put the contents back into this stomach, or you put it into a silo, in either case. What the only thing is that repair, or when you're doing it, whether you're using a silo or you're putting the contents back into the abdomen, the repair causes tension in the abdominal cavity, because the cavity was small and now you push something into this, so it causes tension in the abdominal cavity, and there is a post-operative leak. So always make sure that this is a child who should be on an elective ventilation. Again, the ventilator strategy is slightly higher PEEP and a longer inspiration time. Now, PPHN, if you see this, because this one thing which need to understand is PPHN happens either because of a lung disease, or PPHN happens without a severe lung disease. Like you see the third picture, which is an idiopathic PPHN. We don't know. I mean, it could be meconium, it could be anything, but a child went into, it is so-called a black lung PPHN. Now, when it PPHN comes with other strategies like with other diseases like RDS, like Meconium, like congenital diaphragmatic hernia, in these cases you need like a ventilator strategy and maybe sometimes use an HFO also. But when it is an idiopathic or a black lung, always remember that use of HFOV in this idiopathic black lung PPHN can actually worsen oxygenation because the lung is not a problem and you given expand the lung beyond its like capacity. So overinflated lung reduces the venous return to the heart, and if the venous return reduces, the outflow further decreases, so you're actually causing more harm. So just look at, if you even if you have a PPHN, look at what kind of a PPHN is there and what kind of a right strategy is there for us to follow in these cases. And in normal lung ventilation, these are the ones which are apnea, asphyxia. Again, in asphyxia sometimes you may have like secondary surfactant deficiency, PPHN, but I'm saying is like here what I'm talking is purely an asphyxiated baby, normal lung, a bad brain. And an apnea is like normal lung but forgotten to breathe. In these scenarios, you use the very baseline kind of a setting, like for example, apnea prematurity somewhere around 12 to 14, 4 to 5 PEEP. In a normal lung, the time constant is higher. So if you're in HMD, you keep a setting at 0.35, for example. So in a normal lung, you keep it somewhere between 0.4 to 0.45. And you use the baseline minimum because 20 second rate if you give, the work of breathing increases. So you keep it somewhere around 20, and we're quite okay with that kind of a setting. So if the baby forgets to breathe, like so that is or is forgotten to breathe, this is good enough to maintain a ventilation. In asphyxia, more or less the same kind of a setting. Your rate you could keep it at 30 because it's largely a bigger baby. But here, since we are not doing it for improving the oxygenation, we're just using it for maintaining in a normal lung. So you need a very baseline or smaller settings to help these babies. So in conclusion, what is important is that you should know your ventilator. You should always remember your disease pathophysiology, and then when you keep in mind, you say, okay, somebody case like MAS. So in the ward, do not think in terms of an MAS. Think in terms of what is the kind of a pathophysiology. I look at an X-ray. It is a white-out lung. The chest is not expanding. I know this is a child is like probably has a surfactant and needs an HMD kind of a setting. On the other hand, an MAS, for example, I would say, okay, the child is like now hyperinflated. It's a different strategy. HMD, like before surfactant, is a different strategy. After surfactant, it's a different strategy. So the child with the same disease keeps on evolving. So it's important to keep that in mind when you're ventilating, rather than just looking at one single mode and one single strategy too. And always strive to wean the patient, as like Naveen would somebody would discuss. I think I don't know who's discussing. With that, I would thank all of you, and if you have any questions, I will be more than happy to answer those.